Yeah. So it's a pleasure to have all of you on behalf of SBPI and KKBiotech. We have been doing these kind of programs in the last year. Then there was a bit of gap, and now we have restarted from this time. And certainly, George was very particular that we should talk about tuberculosis because, yeah, just one minute. Yeah, 1 minute. Some people are just checking in. So, yeah, sorry. So I think it's a good beginning. Don't worry about the number because it will be up on YouTube later. So we don't have
Yeah,
to.
yeah, that's true. Exactly.
So the idea is that we share our thoughts, and certainly I'm nobody but to say that you know TB has been always a challenge since Robert Koch discovered the organism. We thought we should be able to solve the problem. It is somewhere in 1882, if I'm not wrong, but we are still faced with that challenge. And unfortunately, India is ranking, he's having 27% of this thing. And I was shocked to see that Delhi has the highest number of tuberculosis cases, which is probably because of overcrowding or whatever it is. So it's certainly worrying, and rest of them are below 10%, rest of the country. So so that is a bit worrying, but I'm sure under our Prime Minister, who is very keen that we try to bring it under control. So he has made a lot of statements, and it is for the scientific community to come out and the public health to help in bringing out. That's what I feel. So now I leave the floor to George to take over and introduce the speaker, and we begin the show. Over to you, George.
Thank you, Dr. Kannan. Now, to brief you on the format of this event, we have 4 panelists or 4 speakers: Dr. Ghosh, Dr. Jaya, Dr. Sathish, and Dr. Krishna Prasad. Each one of them will have 10 minutes for their presentation, followed by 1 minute where they can mention the takeaways from their presentation. So once a speaker has finished, I will move to the next speaker, introduce the next speaker, and likewise to the third and the fourth. So it's my pleasure to invite you all once again on behalf of Dr. Kannan, who is the president of KKBiotech, and Dr. Ghosh, who is the president of SBPI, and also the first speaker. Now, Dr. Ghosh has had an illustrious career. I am taking the liberties of reading excerpts from the write-up. Dr. P.K. Ghosh did his M.Tech in chemical engineering, chemical technology, followed by a PhD degree from the University of Calcutta. He was with the central government, framing policies for basic production and pricing of drugs and pharmaceuticals from 1968 to 80. He was in the Department of Biotechnology, handling technology transfer and policies related to use of genetically modified organisms. And he was involved in the first release of GM crops into India. He worked in 2 public sector undertakings involved in the production of antibiotics. He worked in Cadila Pharmaceuticals post-retirement from 2002 to 2007. He also has a consultancy. In publications, he has more than 100 publications, including 3 US patents. He is a fellow of several learned societies, including the Royal Society of Chemistry and Institution of Engineers. He has a couple of inventions: a novel method for composting, manufacture of hydrophilic polymeric nanoparticles, and MW-based vaccine adjuvants. This is in brief. I know that I have not done justice to his profile, but to keep within the time limit, I'm proceeding and inviting Dr. Ghosh to make his interventions on the topic for the day. And use 1 minute to give the takeaways from your own thoughts. Dr. Ghosh.
Thank you very much, Dr. George John, for your very kind words. Dr. Kannan, Dr. George John, dignitary speakers, participants, ladies and gentlemen. Good evening. I am speaking from Houston, city of USA. Pulmonary tuberculosis caused by Mycobacterium tuberculosis or MTB in brief is a microbial disease of humankind. The disease is rampant in poor countries. TB infected individuals are mostly found in the Southeast Asian region. About 46% of the total TB infected people with disease symptoms are found in this area, followed by Africa, which is about 23%, and thereafter in West Asia Pacific region, West Pacific region, which is about 18%, which makes the total of about 87% in these regions, and the rest 13% is in the other region. Pardon? Pardon? Okay. India has a heavy load of TB patients. According to the latest estimate, India has presently 210 TB patients per 100,000 population in 2021. This figure is down from 256 in 215, which means that India is making some progress. India has plans to eliminate TB by 2025, which translates into 65 tuberculosis patients per 100,000 people. This is good from the present figure, but it is not adequate because I wish to have this figure close to below 10, but that we are not yet ready to go to that kind of figure. Pradhan Mantri TB Mukt Bharat Abhijan, launched by our President in September 2022, has more details on how Indian programs are moving. Indian plan is to diagnose the infected and treat the infected free of cost. Presently, India is providing free treatment to over 1 million TB patients. Treatment cost is centrally provided. Foundational pillar of success in the progress of Indian program, I think, is the accurate and rapid diagnosis of the disease and starting of the treatment. Presently, some 40% of the Indian populations are infected with TB. Of course, most of these 40% do not have the syndrome of the disease. They are called LTB infection. They do not transmit the disease from they are having the infection to others. So all the infected do not have the disease, and these people are called latent tuberculosis infected disease. TB is treated predominantly by therapeutic drugs. The first line of treatment is rifampicin, ionish, pyrazinamide, and ethambutol, which is given for about 6 months or more. If the infected has multi-drug resistant tuberculosis or XDR and also has HIV, then the treatment is indeed complex and expensive. A regimen of bedaquiline, pretomidid, and linezolid, I understand, is used to treat the XDR and MDR infected tuberculosis. Presently, India has over 12 active pharmaceutical ingredients for treating various kinds of TB. Yet, the treatment is not considered adequate in certain conditions of the disease. This makes the necessity for inventing more anti-tuberculosis drugs. In vaccines front, India has only BCG, which is live attenuated strain of bovine tuberculosis origin and is in use for over 100 years. BCG is effective for protecting tubercular meningitis in children, but the protective power of BCG wanes out with age. BCG does not protect against tuberculosis in adolescents or in youth and in more aged people. New vaccines are therefore a great necessity. MTB has over 4,000 genes. Therefore, which antigens of the MTB are to be processed by our immune cells who are infected by the MHC class 1 and class 2 pathways is actually a big problem, because if the processing is good, then it would be possible to capture those infected people of their MTB by the macrophages, and the macrophages would be able to clear. But since the antigens are very large in number, the clonal antibody production against the specific one which captures the maximum one is not yet possible. And because of this, multiple antigens presence, the capturing of the MTB is not adequate, and therefore the disease continues in people. Presently, 5 kinds of TB vaccines are being researched upon. Live attenuated vaccine like BCG, recombinant BCG, and others like VPM1002 and MTB-VAC are used in experiments. In India, Serum Institute is making phase 3 clinical trials with VPM1002 in India. Then there are inactivated vaccines like Professor Tolwar's MW vaccine or MVAC, DAR90 and RUTI. Protein and peptide-based vaccines like M72ASA1 and H4IC3031 also exist. Viral vector-based vaccine AERES402 is in the experiments. None of these vaccines have come out as a jackpot yet. The peptide-based M72ASA1 has shown some good results consistently in African trials, in the sense that the vaccinated ones did not get the disease for over 3 years. However, much is yet to be understood. TB vaccine adjuvants is yet another one area where which I want to flag, because this is also a very important area which will bring success to the tuberculosis vaccines. India has good infrastructure on TB diagnosis and treatment. Research infrastructure is also quite good, although it needs much more improvement. I think that more money should be allocated for more research in understanding about the fundamentals of tuberculosis. Containment of TB is associated, I think, much on the understanding about how it deactivates our innate immune system. How can the resting macrophages not infected can be activated and to more, made to a more active state, so that the infected macrophages where the MTB hides in the phagosomes can be made active, so that the phagosomes mature to acidic pH and fuse with the lysosomes, thereby killing the hiding MTB residing therein. If this could be done, then I think we will win tuberculosis. I have written a review paper on tuberculosis. Those interested may like to read it and consult it in case they wish to know more about tuberculosis. Thank you very much for your kind attention. I have only one important, I think, as Dr. George Jones said, what should be my thinking? My thinking is that there should be much more money allocated to tuberculosis research. This will help our country to go more forward. Thank you.
Thank you, Dr. Ghosh, for your presentation. Now we will move to the next presenter, and after all presentations have been made, we can take questions. So the next person is Dr. Jaya Tyagi, a renowned woman scientist, most distinguished woman scientist of India. Again, madam, your profile is a bit too wide for me to handle, so I will take snippets from it. Dr. Jaya Tyagi has 38 years of teaching experience and 48 years of research experience. She has been known for discovery and characterization of DEV-R and DEV-S signaling system of M. tuberculosis and establishing proof of concept for DEV-R as a dormancy drug target. She's also done work on discovery and elucidating mechanisms underlying vitamin C's dormancy inducing activity in M. tuberculosis and vitamin C's potential as an add-on supplement to standard anti-TB therapy. I understand that these studies are undergoing validation. She is also known for development of TB diagnostic kits. One of her strong points, validation and feasibility studies in program setting has been completed, and I understand the ICMR has recommended this for uptake by the National TB program. These are all her contributions directly related to the theme of today's discussion. Of course, in terms of fellowship, she's a fellow of all the major societies. She has got the DBT Tata Innovation Fellowship, the DBT National Women Bioscientist Fellowship, and many others. And with this, I would stop and invite Dr. Jaya Tyagi to make her presentation. And Madam, I would remind you 10 minutes, followed by a minute where you give us your takeaway. Dr. Jaya Tyagi.
Thank you. Thank you very much, Dr. John, for this very kind introduction. And I would request Dr. Kannan to kindly project my slides. And in the meantime, I will continue following Dr. Ghosh, who has given a very nice introduction and to set the ball rolling for today's discussion. And as he rightly pointed out, the entire problem of tuberculosis treatment is dependent on accurate diagnosis, which includes rapid diagnosis. And second aspect is, of course, rapidly putting the diagnosed patients on treatment. And a goal which has not been met so far is the development of effective therapeutic vaccines. As he rightly pointed out, we have a vaccine that is administered to children. But today what I'm going to do is I'm going to be focusing my discussion on the first pillar of this TB control program, which is the diagnostics. So before going into what exactly we have done, I will just highlight the challenges that actually we face, or the program also faces in diagnosing TB. Firstly, we know that the gold standard of culture is very inadequate, which is why we need to have other methods for diagnosis, out of which the smear microscopy is in fact the most extensively used. In 2022, I saw that the data on 1.39 crore patients were subjected to smear microscopy. So it seems to be the most dominant test that is implemented in the country. Although it is not so sensitive as one would like it to be, but the reality is it is the most widely used test, as there are almost 23,000 microscopy centers which are spread all over the country where this test is implemented. The second challenge is that while we have to deal with a less than perfect test, that is a smear microscopy, and there are molecular tests which are available, but their reach is not as much as that of the less perfect smear microscopy test. So I'll just flag that issue now. The third point is that India is a large country, and we have many areas which are not easily accessible. So the getting the test delivered at such sites is also a challenge. So that brings in one important point, that is there a way that one can transport samples from the patient to centralized laboratories. That's the third thing. Fourth thing is that we know there is a fair amount of drug-resistant TB in the country, which also needs to be diagnosed. And it is not sufficient just to know that the person has TB or does not have TB. And lastly, there is also the aspect of extrapulmonary tuberculosis, which is extremely difficult to diagnose, which is, of course, not as much as pulmonary tuberculosis. Pulmonary tuberculosis is as much as, say, 80% of the tuberculosis burden, but nevertheless, extrapulmonary tuberculosis is very, very important to be diagnosed. So in this context, I want to project only a part of what we have done for TB diagnostic kits, which is actually, if I can have it as a full screen, it may look little bigger, Dr. Kannan, but still it is quite readable, I think. So there are 3 diagnostic kits that thank you. We have developed 3 diagnostic kits in partnership with industry through BIRAC funding and later validated through ICMR funding. So the one kit is for a filter-based microscopy of sputum. The second kit is for safe transport of sputum samples using the TB detect kit, which is safe sample transport, shown on the lower left corner. And third is the TB DNA extraction kit, which enables the extraction of DNA of MTB for molecular tests. The next slide, please, Dr. Kannan. Just to summarize the work on these 3 kits, that the thing about these kits is that we have we have the kits which enable a biosafe processing of sputum without the requirement for equipment, which immediately means that one can do it in a very simple microscopy center. All the 23,000 microscopy centers can actually perform the sputum processing for a smear microscopy, and also process the sputum for collection on filters that can be transported by simply putting them into a plastic envelope, as was shown in the previous slide, for molecular testing. And this is very important because while you have 23,000 odd microscopy centers, the number of centers for molecular testing are, of course, much, much lesser, and they are restricted to larger cities where there are a lot of facilities. So there is a need for transportation of samples from these other areas to the high-end laboratories, which are reference labs. So in this context now, people traditionally, the transportation is done in triple vessel containers with under refrigerated condition. But what our technology enables is the transport of the filter in a simple ambient temperature envelope, and the material is stable. So all these things have been validated, and they have been evaluated in multicentric study in the first one, which was at 6 sites in 5 states. And then because of the good results we got in that multicentric study, then there was a recommendation made by the TB Research Consortium of ICMR to go ahead with an operational feasibility study under field conditions. So that was also completed. And last year, the ICMR expert committee on TB diagnostics, we had thoroughly gone through all the results which were presented. And they have recommended that all these 3 kits can be taken up by the National TB Elimination Program for TB as well as drug resistance detection. So as I said, the molecular test enables one to determine INH resistance, or rifampicin resistance, or fluoroquinolone resistance, or aminoglycoside resistance, basically first line and second line. And the important thing is that the DNA that is isolated is actually completely compatible with the currently used line probe assays, You may be familiar with that, which is an endorsed test which is used in the program to determine first line and second line drug resistance. And just to give you a feel of it, these line probe assays are done, as I mentioned earlier, in the high-end laboratories, and as many as three plus tests were done for the first line line probe assay, and approximately 55,000 tests were done for the second line assay in 2022 data. This is so. If we are able to transport DNA, the samples from peripheral areas, tribal areas, and so on to central labs, then basically we'll be covering a larger population for the important aspect of drug resistance determination. So this is a big takeaway of this transport system. And as I mentioned, this has been thoroughly validated in the microscopy centers, and then transporting the sample from the microscopy center to the high-end laboratories. And it has been done in a coded manner, so there is no possibility of bias. We have obtained the feedback of the users and the scientists on this aspect, and all has been very well received, actually. So in fact, we are ready to we are in fact waiting for the program to take this up, and very excited about it. And the other thing that I will spend exactly 20 seconds is that we have also developed the diagnostics for extrapulmonary tuberculosis, but I don't think I will speak about it now. It's based on aptamer-based detection of the TB antigens, but I will not speak about that right now. I will just like to summarize, because my 10 minutes are up now. I will summarize by saying that the need of the hour really is that, whatever, in terms of, since we know that there is a need for better diagnosis and improved diagnosis, and there is also a thrust of Make in India and so on, due consideration should be accorded to these kits, at least which have gone through the trials and feasibility studies, etc., and for adoption in the program, because there is no doubt that prompt detection is required, and there are large number of cases that are even now missed. So definitely you need better diagnosis. 2022 data is that about the number of people who have been missed is about 2.6 lakhs of people have missed diagnosis of TB in India, which is of course better than it was earlier in few years ago when it was 1 million. So certainly there's improved diagnosis, and active case finding is another area which needs to be given priority, so that one goes into the communities where there are pockets with high density of population, or prisons and such areas where crowding is there and where there could be more. So active case finding is a very important aspect that I would say, and better adoption of developed kits here, and better implementation of the existing program also. So I think there's always scope for improvement. So these are my key takeaways. As Dr. Ghosh pointed out, there has been definite improvement in the performance of the various aspects of the program. But because of COVID, there was a setback, undoubtedly. There's no doubt about that. But I think now things are slowly coming back on track. Thank you. Thank you, Doctor. Thank you, everyone.
Thank you, Professor Jaya. Professor Jaya, former professor, All India Institute of Medical Sciences. I missed mentioning that.
That's okay.
So with that, we would go to the
everybody knows, madam. Everybody knows.
with that, let us go to the next speaker. Dr. Sathish Kumar is a public health professional currently working as the country director at SAATHI. I think, Dr. Sathish, when you give your talk, you could mention a line or two about SAATHI, because many of us may not know that. And you are the person working in the field. He has over 18 years of experience in public health and developmental sector, with specific focus on STI and HIV/AIDS, tuberculosis, maternal and child health, and health access to LGBTIQ communities. He has been working with HIV projects since 2004 and has now been with TB for the last 5 years. So, Dr. Sathish Kumar, we invite you to make your presentations followed by your summary of the takeaways.
Yeah.
Dr. Sathish Kumar.
Yeah, thank you, Dr. George, and thank you all the esteemed colleagues and the guests here. I would like to share a very brief presentation of 3 to 4 slides from the TB program perspective, how the TB program is currently moving in which direction and how things are looking at. Very brief presentation. I'll share this presentation. Sir, is this PowerPoint slide visible, sir?
Yeah.
It is visible, yeah.
Yeah, fine. So I think the previous speakers have already set the stage on the current scenario to a certain extent. Some of the points may look additional information on that. So to highlight how the program, the TB program is looking at current scenario, the most important evidence came from the India TB prevalence survey that was done during the middle of COVID years 2019 to 21, and that got published by 2021 end or 2022. So the prevalence of all forms of TB for all ages in India is 312 per lakh population. And so India is having a very high prevalence of 312 per lakh population, and it ranges from 286 to 337. The range is 286 to 337, and the average is 312 per lakh population. And it varies between states as low as 137 in Gujarat to 747 in Delhi per lakh population. So we can see how our country, we have TB across the various states, so much variation in the TB prevalence. And the prevalence of TB infection among the adult population above more than 15 years age, the study shows 31%, almost like 1/3 of the population, we have TB infection in our body, and it is estimated to have 35 to 40 crores of us have TB infection in our in our body. And the prevalence of TB, pulmonary TB primarily, has been observed among these 5 major risk groups. That is older age group, males, malnourished, smokers, alcoholics, and non-diabetics. The high-risk groups are primarily malnourished, smokers, alcoholics, and non-diabetics, and also the HIV, people with HIV. But as such, higher prevalence is observed among all these groups. So this, we all know this, why TB is there longer period of time in India is because it is still malnourishment is a major risk factor. Smokers, alcoholism, and non-diabetics are the major risk factors. So this this survey helped us to understand where the major problem is, and even though several studies have proven this, but the prevalence survey has established the fact again through a systematic survey across the country. And it is estimated to have 26 lakh people to have TB disease annually. It ranges from 18 to 36, but the average number is 26 lakh people. And so, like Madam explained, we have been reporting few lakh, 21 lakhs, 22 lakhs like that. But in the next slide, I will tell you how much we reached in this 2023. To our surprise, we reached a good level. So I will share what is the current data that shows. However, the TB prevalence survey further emphasized one important thing is that 64% of the people with some TB symptomatic population did not seek healthcare services, primarily due to ignorance or ignoring the symptoms. 2/3, 68%, not recognizing the symptoms as TB, 18%, self-treatment 12%, and not afford to care 2%. So the major challenge the TB program is currently facing is that ignoring people, not aware or not, and ignoring the symptoms and not recognizing the symptoms and self-treatment. So this has to be addressed. And that was one of the primary game changer is going to be that the program wants to reach out to people at the remote areas so that we can really diagnose them at their doorsteps, so that we can really identify symptomatic population at the in the remote areas as early as possible and put them on treatment. And also people who got TB, the TB prevalence survey, they said equal preference for government and private facilities. Actually, they have access to care in both government and private. Almost 50% of them have, means equally reported to have access in government and private facilities. So This TB prevalence survey is setting a lot of strategies for the program to improvise upon. And when we see the National TB Elimination Program, as I was saying last slide, 26 lakh were estimated, and in 2023, the program has reached 25,37,235 cases. It is the highest ever reported TB cases in the program. So it has always been 21, 22 lakhs, and during COVID, again, setback was there. But now with a lot of efforts done in the field for active case finding and various healthcare system strengthening, the project has reached a great level of 25.37 lakhs notification. And this data is going to be published in soon. And this has come from a news article in the Hindu magazine, which I am reporting. And public sector has reached 17 lakhs close to, and private sector 8 lakhs. Private sector has reached 33% of the total notification. But still, private sector is supposed to reach 50%, as we saw 50% equally. Private sector still has the scope to reach some more cases which are missing. And the program has how it has able to achieve the improving TB diagnosis is that active case finding. The first important thing is that the program has classified the population in urban, rural, and tribals around 23 or 26 group of people as a highly vulnerable group. And each vulnerable group has been reached out through active case finding twice in a year, and they go and screen them at the community level. And also added artificial intelligence enabled portable X-ray recently, so that they have piloted using portable X-ray how they can diagnose a person with in the remote areas, far to reach areas. They will carry this like a digital camera. You carry the X-ray machine and then take an X-ray, and then with the internet, with the Wi-Fi connected, you can send the X-ray image immediately to the periphery, and you can get the report immediately. So artificial intelligence enabled portable X-ray machines are being used. Scale up and improve access to laboratory services. Now, like Madam said earlier, the CBNAT and TrueNAT machines were available only at district headquarters. Now it has been scaled up everywhere, that in each district, almost 1 to 2 CBNAT machines are there, and 4 to 5 TrueNAT machines are there, average I'm saying. But now, this is last year report, and now this year I think they have further added the NAT machine. So the molecular diagnostics is available at the sub-district level, at community health center, CHC block level, so that the dependency on microscopy has been reduced, and the increase to access to NAT centers has been strengthened very much. And there are a lot of private sector partnership models. There is a lot of programs are going on with the private sector, with the World Bank funding and various funding. The private sector has been engaged a lot, and that's why this is this 8.38 lakhs is the highest ever reporting in private sector in the country. And lastly, the health system strengthening approach, where they have integrated TB services with the health and wellness center at the primary care level, with the PHC and the subcenter they have integrated, and with other healthcare programs of HIV, non-communicable disease, child health, where bidirectional screening happens between these programs, so that any pregnant woman goes for a maternity care, she's also screened for TB. Any child goes to the health center, the child should be screened for TB. Similarly, non-communicable diseases, they have integrated. However, this health system strengthening approach has been moving ahead now, and it needs a lot of improvement in terms of quality of services, because it takes a longer term to strengthen at the primary care level and across other health programs. So this health system strengthening approach is the next round. We are going to see the result of it in another 1 or 2 years. This health system strengthening approach is going to give more numbers. Now, after diagnosis, increasing treatment initiation has reached more than 95% level, and there is a scheme of every TB patient getting direct benefit transfer of 500 rupees per month for the nutrition support and follow patient support services being available. And the latest last few years being launched is TB prevention through TB preventive therapy for all household contacts and the other risk groups, wherein they have launched 12 weekly courses of INH and rifampicin, very short-term 12 weekly courses being launched, and the uptake has been increasing now in that way. So ideally, the TB preventive therapy initially was given only to child household contacts and HIV people. Now the TB preventive therapy is going to be given for all household contacts of the pulmonary TB patients in that way. So through this, the TB preventive therapy has taken up a good shape, and moving forward, this TB preventive therapy also is going to be a game changer. And last one, the community engagement through the Pradhan Mantri TB Mukt Bharat Abhiyan, as the introductory speaker mentioned about. the program has collaborated with all the departments, especially Panchayati Raj, wherein they have brought in TB-free Panchayat initiatives, TB-free blocks initiatives to really mobilize the community and all other departments at the grassroots level, so that all the departments are engaged for the TB program. And even funding is allocated to the Panchayat Raj institutions for the healthcare improvements, including TB services. And also Nikshay Mitra model is being brought in, wherein corporates and the community can adapt people with TB for treatment and skill development. And the TB champions are identified from the community who are actually leading the approaches of the TB program and the community. Say, for example, in a district, if each and every primary care level, they are going to have one TB champion. TB champion is nothing but a person who has been affected with TB and now wants to advocate for the rights of the people with TB and access to services. So now people with TB are working as TB champions at the grassroots level, so that they can actually engage with the community to identify and also address the stigma around the TB issues. So these are the progress that has been made. However, there are missing cases. Like everyone, all of us know, there are still few lakh cases being missed every year, and that has to be addressed by prioritizing key and vulnerable population. The two missing groups are actually pediatric TB and extrapulmonary TB. Currently, if we take 10% of the total TB or pediatric TB, the reporting is only 5%. So half of the children with TB are missing. Similarly, extrapulmonary TB, as Madam pointed out, still most of the extrapulmonary TB are clinical diagnosis. The samples are not extracted. Say, for example, bone and joint TB or meningeal TB or pleural TB. The samples are not taken and it's not subjected to molecular diagnostics. Most often, clinical diagnosis is being made with extrapulmonary TB. Similarly, for pediatric TB, samples are not collected and sent for testing. So the most important challenge here is the missing groups among these groups, which has to be tested for samples, and samples have to be tested with NAT testing. And the TB preventive treatment, if we see, as I mentioned, it was, if I say 25 lakh TB patients are currently there, assuming four family members are there in a household, we have to reach to 60 to 75 lakh people households contact screening and put them on treatment. But currently we are only putting 15 lakh people on TB preventive treatment. So if we start TB preventive treatment to all household contacts of the pulmonary TB cases, the TB decline can be achieved faster. Current rate of decline is only 2% in India, and it has to be brought to 10% decline. So hence the TB preventive treatment, in another 2-3 years, the program is expecting that it will bend the curve of TB decline. And all oral drug resistant TB has been launched with bedaquiline and delamanid, and they are now decentralizing to all the places. And this has to be strengthened. And most importantly, addressing the barriers in diagnosis. The artificial intelligence has been brought in with cough sound. They have tested with cough sound itself to diagnose TB. There are some encouraging findings and results are coming up. And the artificial intelligence using the X-ray portable machine, which I've said, these are actually piloted, but now this has to be scaled up across the country. And the program is looking at budgeting this in the next 3-4 years. And definitely the newer molecular diagnostics like genome sequencing and other newer techniques like stool TB has to be made available. As of now, these are in the pilot stage. These are not available for are not scaled up. And private healthcare providers, still the reporting has to be gap has to be addressed. And as the previous speakers also pointed out, the adult BCG trial is going on and they are planning to scale up. But however, the newer vaccines are very much needed as the program has to achieve the TB elimination. So to summarize, if the program has to achieve a greater amount of pace of decline of TB, the program has to look at missing cases, especially pediatric extrapulmonary TB and other key vulnerable population like minors or migrants population or people who are slum dwellers, and focus on increasing the diagnosis among them, increase the TB preventive treatment, and address various barriers in diagnosis through your molecular diagnostics and techniques which are under pilot now, and increase the vaccination coverage because there are some promising results coming out with adult BCG trial that is going on as we are hearing, and this also other vaccines has to be scaled up. So I hope that if we make these efforts in the program side with recent scientific advancements happening, the program would be able to reach a good level of elimination in another several years. The program is looking at elimination by 2025. However, we know it is challenging. It is going to be challenging to achieve it. But I think there are a lot of confidence and motivation in the program to achieve it across the grassroots level. Thank you all.
Thank you, Dr. Sathish, for your presentation. We will take up questions at the end of the presentations by Dr. Krishna Prasad. With this, I would like to invite Dr. Krishna Prasad. Before that, permit me to read a few lines about him. Dr. Krishna Prasad obtained his PhD from All India Institute of Medical Sciences, New Delhi, in immunology of leprosy. After this tenure as a postdoctoral fellow, he was appointed on the faculty of the Department of Biotechnology in the All India Institute of Medical Sciences. He was in charge of the TB Immunology Lab, and I understand that he will discuss his experience on elucidating human immune responses that led his team to describe zoonotic tuberculosis. Dr. Krishna Prasad, your presentation.
Thank you. Thank you, Dr. George and Dr. Kannan, for inviting me to participate in this webinar. It's been a great pleasure to listen to the other speakers. However, I would like to point out all the time, all the speakers have been speaking about control programs associated with human tuberculosis. It is all centric towards human tuberculosis. And I wanted to express and describe my experience in working in tuberculosis for the past 30 odd years, where I came across using the immune response studies, and which led us to describe the occurrence of zoonotic tuberculosis. Now, during my tenure in the Department of Biotechnology, as I mentioned, I focused on examining the human immune response to Mycobacterium tuberculosis. We looked at several parameters. We looked at cytokine expression in immunocompetent cells. We looked at the levels of cytokines in circulation. We looked at the quality of the antigen-presenting cells, which are important for immune response. We looked at cytokine receptor expression and the regulation of cytokine receptor expression. Apart from looking at these various parameters of immune response, we also looked at the antigens of mycobacteria. Now, this was important in the sense that laboratory animals and experimental animals, immune perception would be different from that of the humans. And so, when we looked at looking at various techniques of examining this, we discovered a particular antigen associated exclusively or described exclusively with human immune response. The protein that we discovered and described was a histone-like protein of Mycobacterium tuberculosis called HubB. This is a DNA-binding protein, and this protein has numerous other functions. For example, it facilitates the entry of the bug into host cells. It agglutinates RBCs, host RBCs, so on and so forth. It has several functions which are all can be clubbed under what are known as moonlighting functions. While characterizing this gene of the HubB, we discovered there were some differences between two closely related mycobacterial pathogens, namely Mycobacterium tuberculosis and Mycobacterium bovis. As all people familiar with these two pathogens know the great homology which exists between these two species and how difficult it is by using classical techniques to identify them. So using the HubB as a gene target, we developed a PCR assay to distinguish these two pathogens. Now, while doing so, we also developed the PCR assay, and we could distinguish these two species based on the size of the PCR amplicons. Not being satisfied with just looking at one particular gene target, we also analyzed and looked at the MCE operon, which is present in MTB and absent in M. bovis. Use this also as an additional gene target to distinguish to these closely related species. Now, there's clinical samples that we targeted for the diagnosis by the developed PCR assay was extrapulmonary tuberculosis samples. And as all the speakers have mentioned, the difficulty in demonstrating the pathogen in extrapulmonary TB samples. Therefore, that was our challenge, and we took that up. Now, when we started this research program, we also included bovine samples in our study. This was facilitated by the initiative taken by Dr. George John and his colleagues while he was in the DBT department, and that is how we were able to collaborate with the military veterinary laboratory at Meerut and to have a good quality work done. Now, just to briefly say, while using these assays, we discovered that in the human samples, besides Mycobacterium tuberculosis, we also discovered and detected Mycobacterium bovis. Similarly, with bovine samples, we discovered both, besides M. bovis, we also discovered MTB being present in those bovine samples. Now, what does this show you, this observation? This observation denotes that mycobacterial pathogens, which are present in the environment, can infect both humans and domesticated animals. This observation brings to light the magnitude of the problem of tuberculosis in our country. And as people have mentioned, that India has one of the highest incidences and the biggest burden of tuberculosis in the country. Now, just to draw your attention to another related factor, India also has the highest number of heads of cattle in the country. An estimate by the Animal Husbandry Department is about 303 million heads of cattle are in India. Now, various studies, these are not my studies, these are reports from literature, shows that there is a relationship of occurrence of TB between the density of the cattle population and that occurrence of tuberculosis among humans. Similarly, in another study, a meta-analysis and review estimates of the prevalence of bovine tuberculosis among farm and dairy cattle in India was estimated to be about 7.3%. This estimate makes it one of the largest infected herds in the world, about 21.8 million, a population nearly equivalent to the total dairy cows in the USA. Now, this slide shows you the lethal network of the presence of mycobacterial pathogens in the environment and the way they can circulate, simply because across the spectrum there are susceptible hosts and there are reservoirs of infection present in the environment which sustains this in the environment. You can start with humans. Humans are closely associated with domesticated cattle. Cattle can also suffer from tuberculosis of various different species, not necessarily M. bovis and M. tuberculosis. There are other species also which can infect them. And the very fact that the grazing grounds of between the cattle and wildlife are sometimes shared, it can spread into wildlife. So there is this way that the mycobacterial pathogens are sustained in the environment. And I have put one old slogan which was there, which says that TB anywhere is TB everywhere. TB does not respect borders. Therefore, my plea is that we should, besides having human-centric control programs and treatment programs, we have to make sustained and deliberate efforts to develop control programs which will help us reduce or even control the amount of mycobacterial pathogens in circulation because of our domesticated animals. Thank you for your attention.
Thank you, Dr. Krishna Prasad. That brings us to the end of the 4 presentations. Now, what I would suggest is that the floor is open, and if there are questions from our participants, you can raise your hand and go ahead with the question. Dr. Dinakar Raj, I think I saw your hand. Yeah, please.
Yeah, good compilation of TB knowledge. I just have a couple of questions. One is most of the mycobacteria that we see in bovines nowadays belong to the Mycobacterium aureus. And in fact, a lot of Mycobacterium bovis that you also have reported, probably the primers you used could not differentiate bovis and aureus.
Yes.
That's why we see that throughout India and Southeast Asia, we don't see any genome data from aureus also. And we also struggle to find M. bovis DNA, although the BCG is from M. bovis AN5 strain. So just your take on that. The second point I would like to highlight is the kind of extrapolation of the prevalence of 7.5% to the total cattle population of India is probably not the right thing to do, because as you said, it is disease based on density of the animals, based on it's a herd disease. And in India, many of the animals that are maintained are in a few 1 to 2 animals per household. So we have also seen the prevalence, if you separate from herds or goshalas versus individual household, the prevalence in individual households are very, very, very low. In fact, less than even 1.2%, compared to around 6 to 7% in goshalas or in organized herds. So direct extrapolation with the number of animals in India will give you a very overwhelming prevalence percentage, which may not be true. Thank you, sir.
Okay.
Thank you, sir. Thank you.
T.S. Rao. T.S. Rao.
Dr. T.S. Rao, yeah.
Yeah, thank you very much. It was an excellent review of our tuberculosis. Thank you very much, Sir Gosar, and also Madam Tyagi and KP, and also Sathish. Only one question, Maini, where we stand today, that TB Mukt Bharat by 2025, that was declared by our Prime Minister. Where we stand on that? See, it is all fine, wonderful presentations and all that. That like a COVID, that timeline, that mission, where we stand in TB Mukt Bharat. Anybody can answer.
Shall I tell something?
Dr.
Sir.
Sathish? Yes, Dr. Sathish.
I think Dr. Ghosh wants to, please. Dr.
Yeah,
Ghosh,
yeah.
want to-
Sir,
Oh,
आप
I'm
Ghosh
sorry.
बताइए.
I'm sorry, Dr. Ghosh, yes.
No, my point is that even in the Indian program, the elimination of tuberculosis by 2025 is not total elimination of tuberculosis. It is only a reduction of the tuberculosis patients from the present level. We have made a target, as I had mentioned in my presentation, that if we can reach a target of 65 infected with the disease and with disease symptom per 1,000, then we think that we have achieved. China has already reached much less than 65. So you see, without having to think that by 2025 we will eliminate or reduce tuberculosis, it is a dream in the paradise. It cannot be true. Yeah.
Yeah.
So we have to do a lot of work. So I only say that, well, our attention is there on the reduction of tuberculosis, and therefore we are making more efforts. But I had also said, if you might have heard, that diagnosis fast and treatment starting fast is very, very important. As Jayaji was telling, it is not only the pulmonary tuberculosis. There are extra pulmonary tuberculosis, which is also a very, very, very bad kind of state, and there ulcers are there in the body, and you do not know that they are tuberculosis. So if they are treated properly, then only one day we will see a better chance. Now, this, in summary, I want to say that we have emphasis on the reduction of tuberculosis, which is a very good sign. We are putting more money, but we have to go miles away to make a country free from tuberculosis. Thank you.
Sir, one thing, that's not understand. Is there any revised target year or fixing by government, the Sathish, or you can just answer? Otherwise, no, 2025 is we fixed, but that is not meeting the target like polio vaccination. This also had to be revised. No, you can't just have 2025. We are going to eliminate Mukta Bharat, TB Mukta Bharat. So we need to work out on that one of 2030 or 2037 or 2047, whatever it may be.
Sir, true, sir. I think, we represent a technical agency and support the national TB program. So we all, support the TB program in its efforts. So we are waiting for the TB program to revise its targets in terms of definitely practical things. What we are seeing is the decline in prevalence is currently 2% annually, and it has to be multiplied by 5 times. That is 10% decline should happen. So that's then only we can achieve, at least in the 10-15 years we can reach the TB. So the current prevalence is around 312, and as Dr. Ghosh very clearly said, 65 we have reached per lakh population. We have reduced from 320 to 65 per lakh, which is almost like 80% decline to that level. So it's very, very difficult target. I think the program is looking at how to make the change and come out with that in that way, sir. I think sooner they will come back with the realistic timelines.
Okay. Thank you.
Can I respond to what Dr. Dinkar said, please?
Yeah.
Dr.
John, Prasad wants to reply to Dr. Dinkar.
I can't hear you.
Yeah, you carry on.
Yes, please.
Dr. Dinkar, in relation to what you said about Mycobacterium aureus being the predominant organism, there are other species of the MTB complex which also infect the bovines, right? I'm not a veterinarian, as you know, right? This is all from literature, what I'm talking about, where MTB, M. africanum, M. capri, right? And these are also human pathogens. Right. Besides others like paratuberculosis, right, which causes Crohn's disease or Johne's disease in cows, right? And these common pathogens, and MTB itself, I mean, I was surprised earlier on when I was working in it, we thought MTB was an end infection in cattle. But there have been now reports of ulcers and open, granulomas in cows with Mycobacterium tuberculosis. That is a change. Therefore, I think it is important to consider control programs for bovines. Just as much it can go into wildlife and others. There are several other pathogens which we should take care of. If we have not found M. bovis in our bovine samples, okay, because of a technicality, but I think there are other pathogens which we have to take care of.
Yeah. I mean, I'm not questioning the control program in bovines. Absolutely has to be done along with the human program. Even if you eliminate TB, there is always going to be a source ready to infect the animals again. I mean, infect the humans again. So that is totally agreeable. I'm just
very, very
submitting that Mycobacterium aureus seems to be the predominant pathogen, and now the zoonotic TB definition should also include M. aureus, not only presence of M. bovis in human, but also M. orygens in human could indicate reverse zoonotic TB. That's
Zoonotic.
definitely
Yeah,
human and bovine has to be taken
absolutely.
together, if not wildlife also.
Yes, yes, absolutely. Thank you. Thank you.
George, Bindu and Anu are there on with the question.
Yeah.
Anu, are you
Yeah,
going
yes.
first? Should I ask?
Yeah.
Pardon?
Go ahead, Bindu. Yeah.
Okay, thank you so much. I have a few questions with Dr. Sathish. Dr. Sathish, I have never understood the definition of latent TB as to how do you diagnose it. That's my first question. And then, the preventive strategy you talked about, that you are giving, antibiotic to that, because I'm sitting in a place where we see a lot of AMR cases, antimicrobial resistant cases. So sometimes we think, when we said that it could be overdosing of antibiotics without actually working out carefully. In that connection, the hospital has been thinking a lot about addressing healthy household contacts. I don't know whether you remember the trial on leprosy, which were done by DBT, where MW was given to healthy household contacts, and then we saw a huge drop in leprosy cases, and of course in TB in later years. There is a paper by a group from Yenagopa University. It is somewhere in Bangalore. So what they do is they provide nutrition supplements to healthy household contacts, not to the index case. And they saw a drop of about 38% in incidence of TB in those cases. We were thinking, this our hospital is very close to Haridwar, which is an aspirational district. We were planning to do some trial on healthy household contacts of those index cases. The stats out here is 375 cases per 100,000, which is quite high, which is more than the national average. So anything, I would like to get back to you maybe through email or whatever.
Yeah.
But these are some questions which always come into my mind, that how do you define a latent TB and how do you give treatment to those in terms of giving antibiotics. Thank you so much.
Thank you. Can we
Let us see you.
can we have Anu George asking the question?
Yeah. Madam Bindu, I will definitely respond to you a little later after Madam Dr. Anuja asks the question. Yeah.
Sure, no issue.
Yeah. Dr. Anuja, please.
You are muted, I think.
Okay. Yeah, in the meantime, maybe I will share a few points related to this. Actually, the entire concept of this latent TB infection and the TB preventive therapy has a kind of gone through a remodeling, or it has gone through a kind of a new shape now, with several studies has been done on this TB preventive therapy. There are a lot of studies which I will definitely share that. So several studies have shown that with the TB preventive therapy, the among the household contacts, the chances of declining in TB infection to disease, is being reduced in a very much way. Where the study shows that the risk of developing TB disease after TB preventive therapy has been reduced by up to 60% reduction in the household contacts, and up to 90% among people living with HIV. So, a lot of modeling studies has been done, and based on that, the TB incidence decline in the Southeast Asian region, as published by WHO, is 8.3%. Is the decline estimated? So, hence the screening of household contacts for the TB infection, that is the latent TB infection, through the newer one, IGRA test, has been launched, and it has been moving ahead in that way. However, there are challenges and limitations in doing the doing at scale. But now program has really moved ahead and then scaled up at the required level. They have identified laboratories across various points. So there are the household contact visits done, screening is done, and blood samples are taken, and then they do the IGRA test and to see infection. And if based on the infection, if infection is there, then they give TB preventive therapy after ruling out the TB disease. So that is how the model is being done. So hence the program believes that by giving TB preventive therapy using the two drug, earlier it was single drug INH, now it is INH and rifampicin combination drug on a weekly dose. So it is expected that it would decline the TB disease by approximately 60%, and it will decline the annual rate of decline in the country by around 10%. That is based on modeling studies. However, there could be a lot of questions around it, and I would be happy to definitely chat with you, madam, and share all the details.
Thank you so much.
Next question, Dr. Anu George.
Yeah, I have just because in the national program, the molecular testing equipment given, they don't distinguish between MTB and MBOVIS. So some of the cases that we are picking up could be MBOVIS, as Dr. Krishna Prasad was saying. So is the treatment effective for both the same first line treatment? Is it effective for regardless, since we can't anyway distinguish between the two? And how do we proceed with that? Dr. Sathish or Dr. Krishna Prasad, either of you.
Okay. I think the Dr. Prasad sir, please.
Yeah. The current first line drugs used, there are two drugs in it which does work on MBOVIS. And since the patients respond, therefore it has never been necessary to speciate. You know, once you look at a clinical sample, you see an AFB, right? You just go ahead and combine it with other clinical symptoms and diagnose it as TB. And the first line drugs which are used, you know, they are sensitive, the MBOVIS is sensitive to it.
Okay, fine.
That's the only thing. If it was resistant, then we would have sat down and identified it, right?
Okay, so far you haven't seen any of those things.
No, I haven't.
There's no necessity at the moment for speciating.
Yeah, at the moment. But only important from the point of view, if you want to eliminate and control tuberculosis, you have to fight it wherever it occurs. And there are susceptible hosts across species, which has to be taken care of.
Right. Thank you.
Thank you.
I want to add only one point to this point from a very simple program perspective, is that the program has recognized people who consume raw milk or who eat uncooked meat as one of the key vulnerable population under the active case finding guidelines. So the program looks at the group who are consuming raw milk and uncooked meat as that for diagnostic purposes. However, I do not have much experience. Sir has explained it clearly. I just want to bring in this element of program perspective in the active case finding to prioritize the diagnosis of this MBOVIS among the vulnerable group.
Yeah, and to follow that, Dr. Krishna Prasad, how much of protection does BCG vaccination give if it is an MBOVIS? And I mean, is there any study or any data on that?
Whether BCG will protect against
You're
MBOVIS? No, I've unmuted. Can you hear me now?
Yes, sir.
Yes,
You
yes.
can? Okay. Whether BCG would be protective against MBOVIS infection. Well, that example we could only give you, as Dr. Ghosh mentioned in his presentation, the ability of BCG vaccination to protect against tuberculous meningitis. Right? And we, in our study, when we had examined CSF samples, we had detected MBOVIS in several samples of pediatric cases for MBOVIS, besides MTB. Sometimes we've detected both. So your clinical observation has been children who have been immunized with BCG, the severity of TB meningitis and the modulation of the TB meningitis symptoms is far more reduced and controlled, in fact, even prevented to a large extent, where BCG immunization has been done. So that is the only one I can give you and as an example of where BCG immunization has helped in reducing the clinical symptoms of TB meningitis in pediatric cases.
That is regardless of the
Yeah.
species. That
Well, at that level, yes.
Can I compliment?
Yes, sir. No.
Yeah, just to add on, BCG itself is a M. bovis strain, AN5. So it's going to be a homologous protection to M. bovis. So there is no. Of course, there may not be particular studies like that, but it's fair enough to conclude it should be able to protect.
Yeah, I mean, but I'm giving you clinical data,
Yes.
clinical reports where they have mentioned where children who have not been immunized with BCG, the severity of TB meningitis is much more as compared to children who have been immunized with BCG. But in those reports, they have not isolated or characterized the pathogen. They've gone with purely the minute they see AFB in CSF, treatment is started. That's all. In fact, they just look at the symptoms and start the treatment. They don't wait for even the lab report. That's the way it is for TB meningitis.
Yeah, BCG itself is made from M. bovis.
Yes, yes, absolutely.
Can we have the next question?
Disagree with that.
It's almost 1 hour 20 minutes. How long do we want to continue? Do we take up the remaining? How many questions are there, Dr. Bindu De? Anybody else has a question?
Doesn't look like.
Just one small question with Dr. Sathish again. Dr. Sathish, the SIGRA test is highly false positive, sorry. No, it's just a little bit, I'm thinking about it because, in about 2 months from now, we are organizing a conference, a national conference on the AMR. So these are some of the aspects that we actually sit and think about it, that if the test is so highly false positive and then on the basis of that you are giving rifampicin and then INH2 healthy household contacts, is it going to later on impact the total resistant mechanism? Because we are right now looking at increasing the 2% drop to 10% level, but in later part it might backfire, this whole approach. Is my feeling. Maybe I will converse more with by sharing some papers that I have read and downloaded and then get my head clarified.
you're on mute, Dr. Sathish.
Definitely, madam, we can discuss on this. But I think this is a long debate that the program went through, and this concern has been addressed in a way to a better clarity, because it has become a global guidelines WHO has advocated for, and WHO is going ahead in this direction across various countries, including in India. So there is one way. There are a lot of studies on that, but there is one study which clearly says that there is not much of a association between the TB infection status, lack of and the incident TB disease among the people who are given this preventive therapy. And so the study suggests that the WHO recommending that to offer TBT to all household contacts of pulmonary TB patients residing in high TB country. So meaning anybody is infected and getting disease, the risk of getting the disease among this preventive therapy, they did not find any difference. So hence, but whereas the drug as such protects definitely, in that way. So if there is no resistance, no emergence, it's not coming out. So hence, a lot of information available on this, and maybe I think we can discuss across. And this debate has been addressed in a greater way by the program.
Sure. Thank you so much.
I have a question, if I may.
Please.
For Dr. Sathish, actually, you mentioned about the preventive therapy. Traditionally, it used to be based only on INH, so it was even abbreviated as IPT.
Yes, ma'am.
But you mentioned that the rifampicin also has been included now. So my concern is, I'm sure people must have looked at it carefully, but my concern is that rifampicin is such a important drug for treating drug-sensitive TB. And here we are exposing larger number of people to the to this drug, under the likelihood of them possibly getting it later. So, was there a proper risk benefit analysis undertaken to actually opt for inclusion of rifampicin in IPT in the preventive therapy?
Yes, madam. I think there are, maybe I'm little less experienced to comment on this, but I can say definitely, and from the program side, there is a big guidelines called TB preventive therapy guidelines is there. I would love to share with all of the colleagues here. So the first point is that earlier it was IPT alone, it was there, but the earlier guidelines also said 3 months of daily regimen of INH and rifampicin was also there. So there were two earlier regimens were there. One is INH and rifampicin for daily for 3 months. Another one is IPT, which is isoniazid preventive therapy daily for 6 months. But however, this dilemma of rifampicin usage was there very much, and so the program was mostly using IPT alone for 6 months, and they were not using INH rifampicin for 3 months. Now the new drug which has come in is rifapentin, INH and rifapentin, which is also coming to the same group of rifampicin only. Rifapentin, which is weekly dosage for 12 weeks in that way. So the compliance of the drug adherence will be better, and hence the INH rifapentin being used. So this has been introduced after a lot of trials across the various studies being done, and WHO has looked at this drug resistance part of it, and hence the most important guidelines that says that anybody who is having TB symptoms from the household contact screening first has to be evaluated for TB, and after ruling out the TB disease, then only we will start INH rifapentin. So hence the first most important step is do TB symptom screening among household contacts, and then rule out the TB disease before starting TB preventive therapy. If anybody is completely asymptomatic and there are no symptoms and there is no other issues, then we take the blood for IGRA test. And if IGRA comes positive and the TB infection is positive, IGRA positive, TB infection is positive, then we will start TB preventive therapy. Hence, the clear flow chart is being laid out across the guidelines, and the people are trained at the field level, and so they are doing the based on the guidelines. So there is a very good guidelines being available, and across the country it is being rolled out, madam. I would like to share that, and I will also share it other studies also on this which WHO has quoted. I will share it with all of the colleagues here.
Thank you. Thank you.
Yeah. Can I?
Yeah.
Yeah.
Yes, please.
Okay. Dr. Sathish, the only other thing that I wanted to comment about this pre-treatment program was the fact that there are other mycobacterial diseases which also affect us. One among them is leprosy.
Okay.
Mycobacterium leprae, right? And
Yes.
we're going to have in circulation rifampicin or rifampicin, as you said, right?
Rifapentin.
Yeah, rifapentin. Now, hopefully we will not develop resistance to that, and this being in circulation and using it such a widespread thing, rifampicin is one of the sheet anchors for treatment of leprosy.
Yeah.
And if we lose that, we'll be in a big mess.
Yeah.
And I hope that has been considered, to add to what Dr. Tyagi was asking.
Yeah. Definitely, sir. I think the guidelines when it was developed, I think I believe it would have been considered because the experts from across various fields have been part of the guidelines development. And I have limited experience with from the leprosy side, but I think the program would have taken into account of these factors, sir.
I hope so, yeah. And Dr. Anu, I just wanted to tell you that M. bovis is naturally resistant to pyrazinamide.
Oh, okay.
It's naturally resistant, but the other drugs, it is sensitive. Okay?
Oh, okay.
Sorry, I didn't add that when I was discussing with you. Thank you.
So, I suppose we have come to the end of the question session. So, if that is so, can I, with the permission of Dr. Ghosh and Dr. Kannan, can I formally make a vote of thanks?
Yeah,
Is there
please
something
go
that you would like to?
No,
Is
no,
there
go
something
ahead.
like? No,
No,
is there
please go
something
ahead.
Dr. Kannan or Dr. Ghosh would like to add as a last minute remark? Dr. Ghosh?
No, I can say that we have made an excellent evening today. I mean, it is evening in India, but morning in USA. If we actually continue to do these kinds of presentations, at least we will not only enrich ourselves, because we will be recapitulating our own knowledge, but we will also uh, be able to transmit our little knowledge to others. So I think we should do it preferably once in a month, but if not possible, at least once in 3 months, 4 months. And that is what I feel. I'm really excited today that we have been able to host such a nice WhatsApp. Thank you.
Thank you so much. We had a participation of 27. Your 24 was exceeded by 3. So that's a good participation.
Yeah.
Can I remind all the esteemed speakers to send me an email on the takeaways from this? Let us compile it and send it across to somebody who is involved with policy framing. So having said that, let me formally thank all the esteemed speakers, Dr. Ghosh, Dr. Jaya, Dr. Sathish, and Krishna Prasad, for their presentations and sharing their opinion on this problem, which continues to be a major problem. Let us hope that we will be adding some value to our efforts in checking this problem of tuberculosis in India. With that, let me formally thank all of you on behalf of KKBiotech and SBPI for having participated and added much value to the discussions. Thank you so much.
Thank
Good
you.
night.
Thank you.
Thank you.
Everybody.
Night.
Thank you.
Thank
Thank
you.
you.
Thank
Thank you.
you.
Thank you very much. And good